It's my pleasure now to introduce David Leib, who's professor and chairman of the Department of Microbiology and Immunology at Geisel. In addition to David's work on herpes simplex and immunization for herpes, he's played a major role in the proposal for a vaccine institute here at Dartmouth. So please welcome David.
Thank you, Ford, and thank you also to Kendall for putting together this really amazing event today. So thanks to Lizzie also for introducing the concept of maternal immunity, which is something I'm going to be talking about today. Work that we have done in collaboration with Margie Ackerman's lab. And in full disclosure, there is a provisional patent on one of the antibodies that I'm going to be presenting today. So herpes simplex virus is a very seroprevalent infection in the population and is the causative agent of a number of clinical syndromes, including cold sores, genital sores, blindness, and encephalitis. And what I'm going to be focusing on today is the fact that it is especially devastating in the neonatal population. We do have the availability of good nucleoside analog drugs, such as acyclovir and its derivatives, but these drugs cannot treat latency and frequently cannot prevent the reactivation from latency. The intriguing finding, more recent, is the possibility that HSV may be a trigger for neurodegenerative diseases, which may expand the urgency with which we may need vaccines against these infections. So what do I mean when I say latency and acute infection? Primary infection usually occurs at a mucosal site, and this is followed by an unholy battle between the host and the virus, in which the host is trying to exert immune control and the virus is trying to exert immune modulation. So these viruses are loaded with immunomodulatory proteins that can help to defeat the host immune response. At the end of this battle, though, nobody wins. So usually when you get a herpes infection, you neither get better nor you die. It's something in between, which is the establishment of a latent infection in the peripheral or the central nervous system. Now, in terms of vaccine strategies, we have tried to produce sterilizing immunity to ameliorate or prevent primary infection. We've also tried to produce vaccines which are therapeutic, which may prevent the latency from transitioning to reactivation and shedding, which we've heard quite a bit today about asymptomatic shedding. The same is true with herpes simplex virus. This virus is capable of being shed with and without symptoms. When you think about it for a minute, the reactivation is occurring in individuals that have already undergone a primary infection. So these folks are often already imprinted with an immune response. And so the ability of the virus to modulate the immune response when coming out of latency is probably particularly important. That said, most of the time, immune control order is re-exerted and latency is reestablished within the nervous system. Now, as many of you in this room know, there is a veritable graveyard of herpes simplex virus vaccines out there. Sadly, this chart from Current Opinion in Virology is incomplete. It stops at 2017. There's at least 5 more which have failed in various phases of clinical trials. So why is this? Well, first of all, I've already alluded to, this is a virus which has lifelong latency with asymptomatic shedding. It's highly prevalent, and many of the people in the vaccine trials are already seropositive. The only glimmer of hope that we've seen in many of these vaccine trials is actually in the seronegative populations, which tend to be quite small. We are focused as a community largely on therapeutic vaccination. There have been very few trials in the preventative area. The other issue is that immune determinants remain incompletely defined. And as I've already mentioned, this virus is very good at subverting the immune response. And really, for protection from transmission, adult to adult, genital disease, it requires lifelong protection at a mucosal surface. That's a very difficult thing to accomplish. So we have focused on what we think might be the more tractable disease of neonatal herpes. Now, neonatal herpes is a devastating infection. It is a member of the torch family of neonatal and perinatal diseases. Now, neonatal infections can be either local or disseminated, and disseminated disease can be observed with or without skin lesions, which means that you may not actually know that it's going on. The early symptoms, of infection are frequently nonspecific, very similar to bacterial sepsis. So these kids tend to get treated first with antibiotics. And acyclovir treatment, which is the correct treatment, requires a high degree of clinical suspicion and as a result is frequently delayed. That said, even with acyclovir treatment, there is a very high penetrance of neurological sequelae, including learning disabilities, behavioral disorders, and so forth. The neurological sequelae here are very serious. We do, however, have this 2-month postpartum window of susceptibility where if infection is avoided or ameliorated during that window, you no longer see such severe infections. So this suggests that there is a key protection window. If we could hit it, we may be able to prevent this disease. So let's talk about how much of it there is in the world. Depending on geography, the predominant causative agent of neonatal herpes is either type 1 or type 2, but both are capable of causing this infection. It is most prevalent in the Americas and also in Africa and occurs in about 1 in 3,000 births. Now, we think that this is a significant underestimate, largely due to misdiagnosis, lack of reporting, or subclinical infections that are simply not noticed. And rates are clearly increasing. This is partly perhaps due to improved detection methods, also due to declined seroprevalence in the childbearing population, since being seropositive, paradoxically is protective against disease. And I'll talk about this right now. So in terms of the transmission patterns of this disease, HSV acquisition in the 3rd trimester of pregnancy is a very high risk factor and accounts for 85% of cases. Prepartum reactivation in women that have a mature immune response and a long-standing herpes infection, these are actually relatively rare source of cases. Postnatal transmission to the offspring of seronegative mothers accounts for 10 to 15% of cases. All of this put together suggests a role for maternal immunity in protecting the neonate from infection. So, maternal immunity, what's the concept? So, maternal antibody has been known to be key for prevention of many perinatal and congenital diseases. Maternal immunoglobulins can cross the placenta into the fetus, and clinical evidence that I've just presented suggests that maternal antibody protects. Yet we have never tried to clinically translate that information. So the short window needed for protection provides perhaps some optimism for intervention. So what can we do? So what I'm going to present now is some preclinical studies that we've been doing in order to look at this further. So the question is, can this maternally derived antibody protect the offspring? Couple of different paradigms. One is your standard vaccine antigen-induced antibody, active immunity, if you will. The other methodology that we've used is AAV vector-expressed antibodies. So these are vectors that are expressing cloned human monoclonal antibodies. So let's take the experimental outline for at least the vaccine-induced antibodies. So what we have done is to immunize mice either with replication-defective or subunit vaccines. We boost these female mice, and then we breed them and we challenge the offspring. We challenge the pups. So the pups are not receiving the vaccine, it's the dams or the moms who are. And then we look at virus replication, survival, and we also look at behavior. Because remember I told you, neurological problems. So we're looking at behavior in these infected mice. So what we've done in collaboration with David Knight's lab, who provided a replication defective virus, DL529, Harvey Friedman, who provided subunit vaccines, is that we have maternally immunized and then intranasally challenged the pups with 1,000 plaque-forming units of herpes simplex virus. And whether we have challenged with the replication defective virus or the subunit vaccine, we basically get the same binary result. On the left, we're looking at viral titers, and the viral titers of the controls are seen in blue, and the offspring of vaccinated dams are seen in red. So these are viral titers post-challenge, and you can see that the offspring of the vaccinated dams are very well protected from virus replication, and they're also protected from mortality. This is percentage survival over time of the offspring of vaccinated dams relative to the controls. The second paradigm, which I mentioned, is to take a vectored expression vector, AAV, which is expressing predefined antibodies to 3 glycoprotein-specific monoclonal antibodies. So we transduce the mumps, we breed them, and we challenge them with herpes simplex virus type 1, and then we measure expression and the time to endpoint criteria. So we were excited to find, this is work done by Yada Bacchus and published in JXMed, is that we see within a week, we see high levels of antibody expression, which is fairly well persistent over the next 4 weeks. When we challenge these pups that have been born to the dams that are transduced with any of these 3 monoclonal antibodies, we see complete protection from mortality, whereas all the controls succumb to infection. So this suggests that vectored antibody expression is defined, it's persistent, and it prevents mortality. Now, the question is, in most of the cases of neonatal HSV in humans, one of the problems that we see are these neurological sequelae. So survivors of neonatal HSV, even if they're aggressively treated with acyclovir, show lifelong neurological and cognitive defects. So can we measure behavioral pathologies in our model? And also, can vaccination prevent these behavioral problems? So what we've done, rather than infect with a large amount of virus, which could cause encephalitis and all kinds of brain damage, we've developed a low-dose neonatal herpes infection model with just 100 plaque-forming units of HSV. I call this a homeopathic dose. It's really a small dose of virus. And when we give this dose, we see around 90% of the infected offspring will survive. And also, these pups will gain weight normally. This is shown the infected in red compared to the controls in blue. And as I'm about to show you, these mice which are infected as neonates will then go on to show behavioral changes when they become adults. Data that I'm not going to have time to show you shows that the virus is detectable in the brain only by PCR in the CNS. We actually don't find any evidence of replicating virus. It's just PCR positive brains. And we also observe cytokine changes in the central nervous system. So we think that we have developed here a model of neonatal subclinical infection, and these subclinical infections in humans may be more common than we know about. So we've delved into the mystic world of psychovirology. So what we have done, and this is work published by Chaya Patel in Science Translational Medicine in 2019, infecting mice with the low-dose virus, and we test them for the formation of anxiety-like behavior. Put simply, what we do is we put the mice in a box. If they hide in the corners or around the edges, we consider these mice to be anxious. But if they cross the open field, they're considered not anxious. This is the so-called open field test. So if they spend more time here in the open field, they're not anxious. So when we look at the thigmotaxis, which is the tendency of the mice to hang out close to the edges of the arena, when we infect them with any of these 3 wild-type viruses, 100 PFU as neonates, and then we test them as adults, we see an increase in their anxiety-like behavior. The exciting part was that when we vaccinated the moms and challenged the pups, shown in red here, are no longer anxious relative to controls. So we see elevated anxiety-like behavior following HSV infection, and DL529 maternal immunization can prevent this elevation of anxiety. Okay, anxiety. We all worry about anxiety, But what about learning and memory? This is something which our worthy reviewers actually have asked us to do and we've moved into. So we have developed a novel object recognition test, or NOR. So what you do is you throw the mice in a box with two identical objects on day one. They've got 10 minutes to learn about these two identical objects. We then take them away, and then 24 hours later, we show them the familiar object, the object they saw yesterday, and we show them a new one. So mice are just like humans. They like new, bright, shiny things. So if they remembered yesterday that they played with a cross, they'll rather play with the donut. Okay, so this is how we measure this, is looking at the preference for the familiar over the novel object. And the exciting thing is that when we look at the offspring of DL529 vaccinated mice, we show that there is an increased preference for the novel over the familiar object. This shows that there is a normal learning and memory. In contrast, the control mice, they show basically no preference of one object over the other. In other words, they couldn't remember what they played with yesterday. So the offspring of the control mice showed no preference or memory loss, whereas the offspring of the vaccinated mice showed preference for the novel object. So we can conclude from this that maternal vaccination can prevent the memory loss that results from HSV infection. Now, what we then went on to do, and this is work pioneered by Abby Dutton in the lab, is to develop a new behavioral test which is more relevant to humans. So this is called paired associative learning. And this is a test which is given to early Alzheimer's patients to see whether they know which object should be in the right position. So they showed 3 objects, and then they are flashed up on the screen as pairs, and they have to identify which object is in the correct position. Okay? So it's basically a memory test. Now, believe it or not, you can train mice to use a touch screen. Mice will do anything for evaporated milk, and we can train them to interact with the touch screen. So what I'm going to show you here is Einstein mouse, who is touching the correct object every single time and going back to the corner up here for his reward. And you can see that this mouse gets it right every single time. This is where the objects are in their correct position. So we use these things called bussy boxes. They're a semi-automated method that allow us to do this in a medium throughput way. And we use mice that are either mock-infected or infected with 100 platform units on day 1 to 2 of life. And they're tested with this on 4 months later. And what Abby found was that the number of trials, in terms of the cumulative percentage of correct trials, was higher for the mice that were mock-infected relative to the mice that received the homeopathic dose of herpes simplex virus type 1, 100 PFUs. And you can see this difference is significant. So the next thing we wanted to do, and this is work done by Evelyn Turnbow in the lab, was to know whether or not vaccination could prevent this memory change. And lo and behold, on day 1 of testing, we do see a significant difference between the offspring of immunized mice compared to the offspring of mock immunized mice, suggesting that we are able to show protection from short-term memory loss, because if you look at day 12, there's now no difference. So this suggests that there may be just a difference in the short-term memory. Now, why is this so intriguing? Well, there's recent evidence associating HSV and other infections with neurodegenerative diseases. A number of papers have come out recently to suggest this association. Neonatal HSV causes neurological sequelae and behavioral pathologies and learning disabilities. And even very low doses are able to cause measurable inflammation and measurable memory loss. So the question is, could asymptomatic neonatal herpes infections, or maybe asymptomatic infections at any time in life, could potentially be a cause for neurodegeneration? So what I've shown you today is clinical evidence and a neonatal herpes mouse model to show evidence for the ability of antibodies to ameliorate neonatal herpes disease and the sequelae thereof. that maternal vaccination could be effective because of this short time window that's required, and also shown the applicability of AAV-vectored antibody for neonatal herpes and also for other forms of herpes simplex virus infection. We have new evidence from Fiona McEnany in the lab which suggests that these AAV vectors are also able to protect adult mice against much larger doses of virus. We also have shown you evidence that early life or subclinical HSV infection predisposes the mice to memory loss. We're working right now to localize the sites of infection, the sites of persistence and inflammation and damage, and to assess the efficacy of vaccines and engineered AAV-vectored antibodies. The implications here for human disease, I think, are quite profound if mice are anything like humans. And control of HSV infections, we thought it was important from the point of view of genital disease and cold sores and encephalitis and ocular. But imagine if we could prevent neurodegenerative disorders by vaccination against this neurological disease. Finally, I'd like to acknowledge especially Abby Dutton, Cal Garland, Evelyn. There's also Evelyn Turnbow, Fiona McEnany, Matt Sline, and Roberto's data I did not have time to present today, but they're all here if you want to talk to them. Leib Lab alums who contributed mightily to this work, Chaya, Yada, and Sean. And my collaborators, Margie Ackerman and Kate Nordial, who have helped me with the antibody engineering and also the behavioral work. David Leib for provision of the replication defective virus. Alex Balaz, who built all of the AAV vectors that I presented today. Harvey Freeman and Sita and Gary for the subunit vaccines. Funding from the Geisel School of Medicine, Monk Pfefferkorn, which actually kickstarted all of this work that I'm now doing with Margie, and also funding from the NIH and my lab in Plaid. Thank you.